So we have our last symposium, session 13. So this is the ABS Symposium. ABS is a Californian company, and his president is Mehran Khorsandi. He's proposing since years, maybe the last chance to have a dedicated stand to treat bifurcation, especially big ones. And it was, David is gone, but he was still saying a few years ago that the dedicated stent will be the solution for bifurcation stenting. Until today, he was wrong. But regarding the prototypes I have seen through several years, I think that there is a potential for solving the problem with a dedicated stent. So Mehran, please, Mehran Khorsandi, please show us your work.
Thank you, Yves. Ladies and gentlemen, the distinguished panel, thank you very much for allowing us to be here to present. I just want, before I start, I'd like to give a preamble. You must know that you guys here are the cream of the crop. Not everybody has your experience, not everybody has your hands, has your eyes, and has your minds. So whatever solution there is, being with the DCB, with stenting and whatnot, has to work for everybody. So with that in mind, I believe we have found a very relatively easier way of stenting all bifurcations with one unifying technique for all bifurcations. That's a fairly audacious claim to make. We have work to do to show that, but I will show you the potential of that. So I'll start by laying the background, showing you what we do, and I'm going to leave a few minutes for Q&A. So I think the reason for existence is that bifurcation stenting is complex. The complexities are in twofold. We have decision-making complexities in that an operator has to decide what technique they use, and as they take each step, they have to decide, they have to be adept at a variety of techniques to decide what they're going to do next to get the best long-term results. The technique we use also has its own complexities in terms of rewiring the side branches. In case we have to do two stents, they have their own complexities. With DK crush, for example, we want to rewire the side branch through the most proximal stent strut. Then we want to, after the KISS, we want to go through the most distal one. Those are all very complex, tedious, and again, it works in the hands of people who have huge volumes. But whatever we have has to work for everybody, and I think Americans are very cognizant of that. If I can have the next slide. Okay. So high-risk PCIs are performed by less than 20% of practicing interventional cardiologists. Complexities of bifurcation stenting, as well as risks associated with lesion prep in left main coronaries, are some of the reasons left main PCI is not attempted at all by most interventional cardiologists. I think it's now well accepted. These are the very basic rules for bifurcation stenting. Provisional stenting is better. There is a price we pay for a second stent. Have we started that with a second stent because we think the side branch is compromised, or if we add one, the MACE and restenosis is still higher? How do we do a provisional now? We wire both branches, we pre-dilate the main vessel only. We don't want to have a dissection at the ostium of the side branch. These are the things we've learned at the EBC. We pot in order to rewire through the right strut. We go through the most distal strut. We try to find it centrally. We open the cell, then we KISS and repot, and depending on what the side branch looks like, we decide what to do with the side branch. We compromise with the side branch. Because there's a price to pay for fixing that side branch with a stent, we leave good enough alone. We say if the residual stenosis is 50, 70, 75%, leave it alone. We FFR it. We say if the FFR is good enough, leave it alone. We don't do that with non-bifurcations. So the reason we do that is because there's a price to pay for fixing that side branch with a second stent especially. And so I want you to think about this, which I'm sure most of you have. Current stents and delivery systems are designed for vessels that are cylindrical, where two dimensions, two variables matter only, diameter and length. The interventional community has tediously and very creatively found ways to place these cylinders at bifurcations where there's a third variable at the coronal region. I'm stating the obvious. By definition, there's some stent deformity with what we do and a high probability of some malapposition. Even more so when we have two stents. And then if in the primary two-stent techniques, we have multiple layers of stents. As such, recommendations and regulatory guidelines for shorter duration dual antiplatelet therapy specifically exclude bifurcations. Most of us don't stop dual antiplatelet therapy when we've done bifurcation stenting, unless we are absolutely confident that we have apposed the tissue and we don't have malapposition. So I want you to consider something. What if we could stent bifurcations seamlessly, the way we do non-bifurcations, leaving a symmetrical scaffold behind that molds the bifurcation anatomy, extending into the carina, extending into the ostium of the side branch without any deformity or malapposition. So we have essentially our uniqueness is a delivery and stent integration system, which is now 6 French, is a very good 6 French, is nearly 5 French now, which simplifies the technical and decision-making aspects of bifurcation stenting. It's designed to mitigate the pitfalls of current bifurcation stenting techniques and lead to a symmetrical deployment of a stent at the bifurcation with protrusion into the ostium of the side branch without any deformity. As such, it enables stenting of all bifurcations in a simple, reproducible procedure designed for better angiographic outcomes and guaranteed continuous side branch access. The best way to show it is with an animation. I will show you more. Animation alone cannot capture. Can I have the sound? Okay, I'll speak to it. So we've tried to show the third dimension here. We're trying to show a bifurcation with a perspective. Remember, everything we do is on paper, or when we show is two-dimensional. You have to put your three-dimensional hat. It's an independently movable dual catheter system. The catheter that goes into the side branch can move back and forth. After pre-dilatation, we go to the carina, we pull back a few millimeters, we pull the side branch balloon back, and angiographically, we put the two markers next to each other. We go back to the carina, and here's the key to our technology. We inflate the side branch balloon first. This causes the necessary phase shift, the automatic alignment of the proximal segment of that stent looking down the barrel of the side branch. The wire bias goes away during that balloon inflation. The wire is centered. The ostium of the side branch is covered. We inflate the main branch. We're based on the Murray's law, and then we kiss, and we go to the next step. So while we are mainly about a delivery system, and it's taken us some time to make it almost a 5 French system, we also have uniquely designed our stent in that our stent is designed as such that proximal to the carina, the stent pattern allows for a much larger diameter. As such, our 3.0 stent goes easily to a 5 millimeters without any deformity, and our 3.5 stent goes all the way to 6 millimeters. And remember, it's not a uniform stent. That's the segment proximal to the carina. We try to be even once we're done. So although our provisional systems for stenting side branch are relatively simple, we make that simple even simpler. What is unique about us is that we don't have to rewire the side branch. The alignment to the side branch and covering of that ostium is automatic, and this is very, very important. And there's no stent deformity when we're done. This is something which I have to show you. The only way I can show you this well is by showing you in high magnification. So this is a plastic model. You see the flaws in the model. You see the glue that has put the pieces together. I want you to look at the segment of the stent beyond the carina. Look at this part. While the balloon is coming up, look at that part. See how it turns and looks down the barrel of the side branch. So, and again, in order to capture that, we're going at a very slow motion. Watch that, watch. You see that? That is something we can't do now. We deploy the stent in the main branch, and the face of that stent is sealed. Now we're looking down the barrel of the side branch, and again, in slow motion, you would see the main branch balloon come up. Now that we're looking down the side branch, and the stent is deployed. The other thing which, as we deploy, I want you to see, we've put different coloring so you can appreciate each balloon better. And by the way, our catheters also have different colors so you can easily say which one's the main branch, which one's side branch. So we're very slowly inflating the main branch balloon. Look at the struts that protrude into the side branch. That strut is essentially perpendicular to the axis of the side branch. Should we require a second cylinder, a second stent, it's a T-stent. It's not a complicated procedure. It's the same way you stent any other non-bifurcating lesion. You just have to take care of the two dimensions, decide how long the stent needs to be. So that's essentially the crux, and as you see the main branch balloon getting inflated more and more, it's coming together. I'm going to let it play for one moment, because as we deflate, you will see the part that I'm talking about. And again, it's very hard when we look at such high magnification to keep all the stent struts in focus. So some of them are out of focus because they're in different depths. And again, we deflate and we pull back. I think it's pretty obvious. And for the sake of time, I'm going to go to the next slide. Look at the proximal part of the stent is not deformed. It could be stretched even more. And while we go with the Murray's law in terms of, because of the flow dynamics, the stent diameter at the carina, depending on the angle of the side branch, can be stretched much higher than what we calculate with the Murray's law, with the Finet's law. Okay, so the quote-unquote simplified approach to the treatment of bifurcations is shown on the left. This is what's published. That model is actually by Dr. Raab, who's sitting in the audience, which I had the pleasure of running into yesterday. Please note, on the left panel is actually what we are calling it the simplified approach, and that's not my saying. This is the published. And we go from that to one solution, and if you see any residual stenosis in the side branch, you'll deploy it. I think we're talking for drug-eluting balloons appropriately now, and we're, for the most part, saying we're going to leave good enough alone. But we need a system which takes care of all those things which was mentioned. We are confident when it's done, there's no dissection, there's not going to be a thrombosis, and we have the largest diameter according to the size of the vessel, and I believe we do that. And I will show you how far we've gone and what else needs to be done. This is a micro CT of one of our devices. This micro CT looks so good that if I don't tell you it's a micro CT, you think I've animated this. This is a micro CT without a pot, proximally, and that's why you see the proximal part is ovalized. This is very interesting. My colleagues at Boston Scientific actually sent this to us. You see the artifact. This is a micro CT of a synergy stent on our delivery system with a second stent in the side branch. Again, at least in the model, it looks perfect. So based on this idea, several years ago, just after which I ran into Yves and Thierry, we put systems together from off-the-shelf stuff. We wanted to prove the concept. As such, this turned out to be an 8 French system. We had hand-crimped partially these stents because we had to be able to move the proximal segment. This is the very first one we did. This was a stainless steel stent, 8 French system done in Sao Paulo with Alex Avizet. And this was a 59-year-old gentleman who had come in with an acute MI. You see the middle segment was stented first. And the key thing is that we stented that bifurcation of LAD and diagonal after that proximal segment was stented. That means our device went over the 2 wires through the stent and made it to the bifurcation. Once we felt confident, we moved and we did a few more in humans, again, with our 8 French system, just to prove our concept to ourselves. This is a provisional system. This was done with Jose Condado in Caracas in Venezuela. As a Medina 111, you see the system at the carina. You see the side branch balloon distally. I'm going to go through it quickly. You see the markers pulling back. We align the two. And there's their alignment. We inflate the side branch first. We inflate the main branch next. And here's the final result. I'm going to show you an eagle eye going through with ease into this small branch because there's no stent deformity. It's a railroad. It's completely open. We go from that to that without a stent in the diagonal in that case. This is a widowmaker. There's a patient with subtotal stenosis of LAD and diagonal, very shallow angles. Shallow angles tend to be more problematic. They're harder to get a good results with the shallow angles. I think most people would culotte this. There's also Cirque disease. Again, the system at the carina, the side branch marker is way down if you see it. And in the next panel, you see the side branch very slowly coming back. So we'll align those 2 markers, inflating the side branch. The level of contrast is trapped there, inflating the main branch. And in magnification, I'm showing the bifurcation. Look at the smooth transition. There is no pinch at the side branch. Is very unusual for us, no matter how good we are and how lucky we get, not to have a teeny tiny pinch at the side branch. And here's another view of the same thing. Okay, now we keep talking about LAD diagonals. Most of us hate doing bifurcations elsewhere. They tend to be more distal. They tend to be more difficult. Sometimes there's smaller side branches. We say, forget it. Here's a Medina 111 PDA-PL in a fairly calcified right coronary artery. Again, wired, pre-dilated, and I don't think we have any technology that can get you the results we see here. This was done with Samir Dani in Ahmedabad, India. And I'm going to show you one more, which most of us hate doing. This is a grungy, plaque-laden circumflex obtuse marginal 1. And I'm making a point of showing it in rotational panning on the right panel. Again, look at the smooth transition into the OM. This is, I believe, as physiologic as we could make molding the anatomy. So where are we now? So we kind of proved the concept to ourselves. It was essentially myself and one engineer who's a veteran of the industry, and the two of us set out to make this as refined as possible. Obviously couldn't have an 8 French system. We moved to 7 French, and we've moved over the years. We have found all sorts of technology to make our dual catheter system a lot smaller. We're nearly 5 French now. And you can't have a device without a drug on it. It's taken us a couple of years. Now we have actually a 4th generation polymer is made by a company actually in Germany. It's the least inflammatory, if you will. We have completed our animal implants required for the FDA. We met with the FDA a couple of years ago as we were going through this. FDA convinced us to have a US first policy. They said they will help us move things through as much as possible. That was around the time that the European Union regulatory system was changing, so we almost didn't have a choice, but now we're doing both simultaneously. And we were lucky enough for FDA to grant us a breakthrough device designation several months ago. So we have completed the drug-eluting version of our device, which I'm saying is nearly 5 French in the pigs. We're submitting that data along with a prerequisite bench testing of nearly 7,000 devices in order to start our human trials in the US and in the European Union. And if everything goes according to plan, we're targeting to be in the market sometime in late 2026. Obviously, a lot more studies have to be done to validate what I'm saying, and we will find things to make it even better, and we will find if there are any pitfalls, and we'll get better at it. So we're gearing up for that FDA trial, and we will nestle the CE mark into it, and we're looking forward to the work that needs to be done. Thank you.
Dear Mehran, this is very promising device. Yeah.
Patrick is asking for the question.
So, Mehran, between, I think, 2010, 2016, there was the time of the dedicated device. And it's very refreshing to see you here for the 3rd time, I think.
More.
So, more. Okay, so I remember Mehran, and it took a long time, 2016, if you take that as a, not starting point, but at least getting public. And we are in 2024. You are an entrepreneurial person. What is the problem? What is the difficulty? The money, the coating, the drug, the regulatory, why it takes so much time? While
Excellent question.
In 2010, there was 8 companies with a dedicated device, and all disappear. Tell us. I'm really curious to know
so
how
there are
we
2
can
questions.
help you.
First of all, the answer to your question, what took so long, is all of the above, and I will elaborate more. In terms of all the other companies, I want to remind you guys that almost all of the other companies actually had CE mark. Under the old MDD system, it was not as hard to get a CE mark. And the reason they did not survive is because they did not make life any simpler, and they did not have better outcomes. So even though they were on the market, at least in the European Union, and one of them in the United States, it did not fly because they were not used. What took us so long is that, and how come we stuck to it? Because once we had done with the clunky 8 French system with a stainless steel stent, we knew this thing works. Technologically, to get it to be a nearly 5 French, to move easily through a radial 6 French axis, was a major feat. These are not 2 off-the-shelf balloon catheters to make it such a low profile. These are not hydrophilically coated catheters. Hydrophilically coated catheters actually, when placed together and stay in the environment, they actually tend to stick together. So we have special polymers to make it move very easily. We've done special things to the distal parts of the system to make the 2 balloons next to each other substantially rounded and not necessarily oval. We had to put a cuff on the proximal segment of where the stent comes out because a part of the stent is not fully crimped. So the cuff protects it if you have to come back into the guide catheter. A lot of little technologies had to go to make it possible. Money was an issue too, which we raised as we went, but money definitely was an issue. And then all drugs were proprietary. Not only drugs were proprietary, coatings were proprietary. And for a device to go through the FDA with a drug, you go through 2 divisions. So it became a very, very difficult thing. Sirolimus came off patent. So that's why we see so many sirolimus-eluting stents. And we had to find the best way of coating it. So while we solve the problem mechanically, we don't incite restenosis. So it took us a couple of years, 2.5, 3 years, just to address the drug, although we're not about the drug. And that's why it's taken such a long time. As we were struggling and doing all these things, we actually asked the FDA if we qualify to apply for a breakthrough device designation, and FDA said, you don't need to ask. You have breakthrough device designation, because they saw the merits, I believe.
Mehran, maybe we can leave 1 minute to Imad, because after that we have to have a very short pause of 5 minutes and come back for the 2 next sessions. Please.
Actually, we worked on a similar device in the 90s that was from Invatec, twin rails. And
I'd like to comment on that.
main two problems were crossover wires and the length of the stent was not fitting with all lesion, length of lesion. So you have to add, often you have to add another stent proximally or distally. That's the main limitation, I think, for such.
Invasive had another issue in that even though there were dual catheter systems, it's important to realize invasive system was fixed. The 2 catheter relationships were fixed. The way you deployed the invasive system was you would deploy it in the main branch first. You would not be able to take care of the wire bias. And after you did that, you would advance the side branch. By then, the die is cast. The other issue with all 2 catheter systems like triremia and invasive was the wire wrap, as you mentioned. Again, because the 2 systems were wrapped, and the connection between the 2 is fixed. I have bench testings which show we simulate multiple wraps, and actually our system mitigates the wrap. The 2 go around the wraps and push the wrap behind. So again, these were among the things we had to do as we realized there were issues with other systems. I have a table actually which shows all the devices that have been in the system, the DVAX system, the Zions SBA, the Boston Scientific's pedal, and what were the shortcomings of each. For example, the pedal system was a beautiful, beautiful stent. The issue with that was we couldn't put it at the bifurcation with the appropriate orientation. And that's essentially what we've solved.
Mehran, you are the last chance of dedicated stent to win.
Thank you.
What was David was telling 10 years ago, maybe, the dedicated stent will win. For the moment, he was wrong, as he said. So
we have work to do.
We are supporting you. Next year, if you need help in all this audience in Europe or elsewhere, we can transmit your message.
Yeah, I just have to say, we love our EBC family. We definitely learned here, and we've adapted our systems to what we have learned here. And I can't thank you enough.
Thank you.